that you will need.
And then Dr. Grant, just to verify, you'll be sharing the slides?
Sure, sounds great. Can I pull them up and do that now?
Let's test that.
I'm yeah, I feel like I never fully caught on to the Zoom virtual meeting trends. So I'm just gonna want to go.
Great. And it looks like Bridget's on and she's got co-host powers. Hi, Bridget.
Hey.
Hey, Bianca, were there additional slides?
Yeah, in the beginning, you scroll up to the, let's see if it's the one I updated. No, did you get the latest one, Dr. Grant?
I do not believe so, no.
Okay, let me send it again. I'll forward you the email I sent. Let's see.
Good to see everybody. Thanks for doing this.
Yes, thank you, Dr. Grant, for.
Oh, my pleasure. Honored to be asked. Hope to not disappoint.
Sure, you'll be great.
This is the last one in the series.
It is, yeah. Well, we have one on cannabis in October. Yeah.
Who's doing that?
That's Sean from the Comprehensive Center for Pain and Addiction. They got a ADHS grant to provide education on cannabis, particularly for healthcare workers, personnel, as well as young people in the community.
Okay, Dr. Grant, I forwarded you again the email. Let me know if you did receive it.
Nothing yet. I got your email replying to my email about being let into the meeting, but out there.
Okay, you there. Okay.
Want to download. Hold on. Open. Protected OTP. Notes. All right. Yep. I appear to be in possession of the slides, and we will test my ability to share them. There.
Yes.
Is it display? I probably gotta do that.
Perfect. So I'll go over the first few until your bio, and then I'll pass it on to you.
Okay, sounds great.
How's the family?
Oh, they're good. You asking me?
Yeah.
Oh, yeah. The baby Ben's almost 6 months old now. He just started daycare. His mom went back to work teaching high school math, so adjusting to that over the last few weeks, and then little almost 4-year-old daughter's doing great. We're all adjusting to the new demands and lacks of sleep, but overall very grateful and blessed.
Fantastic. That's awesome. And how's
Mark, where are you based? Are you in Tucson, Phoenix, or somewhere else?
Based in Tucson. I work at are you all Tucson T-Lokes, as they say? Yeah, so I live kind of by Tucson Medical Center, and then I work at CODAC's opioid treatment program over on like First and Fort Lowell.
Great, yeah.
How are you liking it?
Oh, I love it. It's been fun. It's been challenging, but I feel like most jobs are challenging, and the challenging things I have to deal with are pretty tolerable. So yeah, interesting time to work in the space with some of the changes to the federal regs and such, and yeah, so
Mhm.
Good thing, yes? Sort
I
of?
think so.
Yeah, I do too.
I feel like I don't know, like a little bit nervous, just like being in a position where like of like medical legal liability, right? That makes me a little bit nervous, but I feel like in general, like particularly in the opioid treatment space, that there's a disproportionate uh, emphasis placed on like mm, keeping patients safe, and kind of like neglecting the things that we don't allow or do, that like the errors of omission that are actually like a ton more prevalent and more harmful than like the potential harm that can happen if patients actually get access to a life-saving medication. So
Right, definitely. And have you met Bianca or Jen before?
uh possibly last year at the previous ones. I don't think I've
Yeah,
ever met any of you all in person though.
yeah.
Yeah, it
Jen,
has
you want to
it
go
has
ahead?
been some time, but I do believe that we did meet last year.
Okay,
Yeah.
very good.
So I'll probably stay on for like the first 15 minutes of the webinar, and then I have to hop off to go to another meeting. But I think that I haven't seen the registration role for this webinar. I don't know if either of you have, if that was shared or anything. So I guess we don't really know the number we're anticipating for people to sign on. But regardless, it's recorded, and it gets posted as a resource after the fact. So that's really good.
That's really good.
Hmm.
Really helpful. Well, thanks for letting us know. And I don't know if you can, when you hop off, if you can either make Bianca or myself the actual host.
Yes.
So that,
Yes. So
okay.
Bianca I've transferred the host to Bianca already.
Beautiful.
And actually that seemed to remove me as the host, so I no longer have any power. Bianca has all the power.
Fantastic.
So Bianca, I think when I look at the participant window, it says that Bridget is a co-host. So I think you guys both have all the power that you'll need to let people in, to monitor all the chat. It looks like it's already recording, so that's good. You don't have to remember about pressing that button. It's already going, and we'll edit out this first 15 minutes.
Thank you.
Yeah.
And I need to transition the initial slides for you, Bianca, or do you have capabilities of doing that?
No, I think since you're sharing, you have to. I'll
Okay.
tell you when to move. Yeah, next slide.
Okay, sounds good. And then
Thank you.
nothing at the end, other than Q&A?
No, just the beginning. And then I'll facilitate the question and answer portion in the end.
Okay, and you want to start that at quarter till? Is that or 10 till?
Yeah, we hope so. Unless, if we go a little bit over, I think it's okay, but just a little bit of room too, if there's any questions or.
Okay, and to clarify, 11:50 or 11:45 you want me to aim for?
11:50, I think would be good.
Okay.
You're good on timekeeping. You're usually really good about doing that. Yeah, Mark.
Yeah.
All right, good.
And,
And I'll just I'm kind of just hanging out, learning and listening. So if you need me specifically, call me out. Otherwise, I'll just stay quiet in the background.
Do you want me to send you a message, Mark, when it's 11:50 or just?
sure.
Okay, I'll send you a message just to you, reminding you.
Yeah, I'll set like an alarm on my phone for 11:48 or something, so. I think you're also currently like the top of the 4 people I can see in my video, so you can just like wave your arms in the air, like
Yeah.
letting me know that I'm going overboard.
Well, hopefully we'll have an opportunity to do a little bit more of this next year. So if we'll reach out if we are able to do that and see if you're interested and available.
Sounds great.
Hoping to do maybe another in-person training sometime next year, but perhaps in the southern part of the state instead of the northern part. So maybe in Santa Cruz County or something.
Oh, nice.
Yeah, Cochise County.
Let the mountain dwellers escape the snow and come down to the warm southern parts for the winter.
There you go. Sounds good. Looks like we got folks entering already. It's good. I'm gonna go ahead and turn my camera and mic off.
Well, we'll be starting shortly, a couple more minutes, waiting to see who else will be joining, and then we'll get started at 12. Okay, we're gonna go ahead and get started. Good afternoon, everyone. My name is Bianca Santamaria, and I'm with the University of Arizona Center for Rural Health. Welcome to the webinar series. While we have people joining, we would like to take a minute to express our gratitude to Dr. Mark Grant for partnering with us to provide this webinar. Next slide. Okay. So the audience will be muted during this webinar. Please enter your questions into the chat box. We will be addressing them at the end of the presentation. So if there's any clarifications or any questions, please enter them. You will also receive a follow-up email with the survey and the link to the recorded webinar. We would appreciate you taking a moment to complete the survey as well, as it really helps to have your feedback. Next slide. Okay. We want to take time to respectfully acknowledge the University of Arizona is on the land and territories of Indigenous people. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. Next slide. Okay, and now it is my pleasure to present Dr. Mark Grant, who was born in Phoenix. He returned to the Southwest after completing medical school at Loyola Chicago. He completed his family residency at the University of Arizona, where he developed a passion for working with the underserved. Seeing the impact addiction had on patients in the Tucson community, Dr. Grant pursued a fellowship in addiction medicine to gain the skills that would help him better serve this population. Mark is currently actually the Medical Director of Addiction Services of CODAC, OTP in Tucson. And now we'll pass it on to Dr. Grant. Thank you.
All right. Thanks for the kind introduction, Bianca. And thanks everyone for joining the lecture today. The theme of today's lecture will be screening, brief intervention, and referral to treatment with a focus on OTP or opioid treatment program, also kind of more colloquially known as methadone clinics. So some learning objectives to start off the day, hoping that by the end of the presentation, everyone will become familiar with common screening tools for substance use disorders, or SUD. That we all will become familiar with brief interventions for SUD, and delving into the OTP, referral to treatment portion of it here. Become familiar with medications for opioid use disorder, MOUD, and the various types that are currently available. That we can help you all develop plans for referring patients or community members that you may encounter to opioid treatment programs. And kind of taking a further and historical step back that we all can kind of gain a little bit of familiarity with methadone in particular as one of the types of MOUD. Its history globally and in America in particular, how regulations surrounding how it is prescribed and administered are beginning to change for the first time in many decades, and how you as members of the community can help connect patients with care for MOUD and advocate for further change that could allow increased access to these medications that are incredibly life-saving moving forward. So we'll see how we do at the end here. But just to kind of start off here, over the past 2 years since I started training in addiction medicine and working in the field, whenever I've given presentations, the tone is rightfully a little bit somber. But I think it's important to kind of start off today acknowledging some of the impact of the incredible work that people working in the space and field are doing. When I've been presenting this chart over the past couple of years, it's always been on a upward trend that seems to be never ending. But as of this summer, as you can see here, these are the opioid overdose mortality rates over the past year. And as of July, for the first time since I've been monitoring them, they've actually started to take a downtrend, which I think is relieving and very exciting, and is probably in part a direct result of the hard work that everyone's putting into the space. This graph kind of just breaks this down more regionally within the United States of America. When you're looking at the graph as a whole, if you're like me, you're probably reflecting back to geography class in 4th grade and trying to remember which state is which. But the overarching theme is that blue within the state means that the rates of overdose deaths have been decreasing. And the orange or red or amber yellows are the rates are increasing. And so you can kind of see here is that as a whole, the overdose rates have decreased about 7%. And you can see Arizona and California there kind of as a little bit of an island within the southwestern United States, surrounded by some states in which overdose rates have been increasing. And so kind of cool to see the rates finally starting to downtrend as in the country as a whole, and in Arizona in particular as the state in which most of us are probably residing in. All right, so to get down to business here, we'll go over a little bit of a case study here to kind of help us better understand some applications of screenings, brief interventions, and referrals to treatment. I don't have any fancy Q&A feature here, so I'll just read through them and we'll go over the answer choices to help us gain the understanding. So you're recognizing unaddressed needs for substance use disorder treatments in your clinic or your place of work, and you want to implement an evidence-based screening tool. Which of the following options would be appropriate? Option A is that you decide to implement applications of DSM-5 criteria for substance use disorders. Option B is that you implement the single question drug screen. Option C is that you implement the NIDA quick screen. Option D is that none of these choices are good options in screening for substance use disorders. And option E is either B or C. All right, so for this question in particular, option B and C would be good options. Option A is how we're currently diagnosing substance use disorders. So that's kind of a next step after a screening tool. So while it's a way to identify a substance use disorder and diagnose it, it's not a screening tool. And then either option B or C, the single question drug screen or the NIDA quick screen, are screening tools that could be implemented in your places of practice to start screening members of the community for substance use disorders. Obviously, there's many screening tools that can be used, a very wide array when I was doing the research and getting the presentation together. But I just thought these two were a little bit interesting as specific examples, and we'll kind of talk about why as we go through here. So the single question screening drug screen is just a simple, as it's stated, one question screening tool. And the question is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? The sensitivity of the screening tool is about 100% for substance use disorders, which is as good as it gets. And the specificity is 73.5%, which is still pretty good. In my opinion, the benefits of this screening tool are that it's incredibly quick, and that it's very sensitive, and the specificity of it is pretty good as well. The drawbacks are that it's only focused on like recreational drugs, if you want to call them that, and it's not screening for alcohol or tobacco use disorders. The lecture today is kind of geared towards opioid use disorders in particular, and so I think that if we're talking about trying to identify opioid use disorders within our populations, that this is a pretty simple and effective and accurate screening tool. But obviously, if you're wanting to identify alcohol use disorder, tobacco use disorder, wouldn't be a good option. Next, we're going to talk about the NIDA quick screen, which was option C here. So either B or C, the single question screening tool, or the NIDA quick screen would be potential options that you can use. And again, there's more options that could be employed as well. So you can see in the upper left-hand corner what the initial aspect of the screening tool looks like, the NIDA quick screen. And taking it for face value, it's a pretty quick and efficient tool. If the patient answers no for all the substances screened for, your screening's complete, and you can kind of move on from the screening tool. Only a few substances that it's screening for, broader, including alcohol and tobacco, as we discussed, the previous screening tool does not. However, some of the drawbacks, as we'll see later, are that if you screen positive, in particular for illegal drugs, that it gets a little bit cumbersome to perform in a clinical setting, in my opinion. A positive about it is that within the tool itself, it has some pretty good brief interventions that it refers you to and some other resources from the NIAA. But we'll kind of talk a little bit more about in my opinion, why it might be a drawback to use this if you're screening for opioid use disorders in particular. For the illegal drug section, if the screening is positive, you have to refer to, as it says at the bottom, to question 1 of the NIDA modified assist. And as we go to the next slide here, we'll see the question 1 of the NIDA modified assist version 2.0. This isn't the full question 1, and then as you can see, there are 8 questions in total, each being about the same amount. And so once you screen positive, this is probably going to take like anywhere from like 10 to 30 minutes, I would think, to sit down with a patient and go through it, which depending on your clinical setting, might make it a little bit more time consuming than would be ideal in utilizing staff resources as well as respecting patient times. But at the end of the day, like I mentioned, there's more than 2 screening tools that can be effective. And it's kind of just based upon your team and your own preference, what you think would be best for your clinical or community setting. Picking one tool and kind of sticking with it so everyone's on the same page and you can kind of get a rhythm with it, making it more efficient and more effective in screening patients for substance use disorders, in particular the ones that you're looking to, because the single question drug screen, like I was mentioning, does not deal with substances outside of recreational drugs. Efficiency of the tool, in my opinion, is pretty important. Maybe that's just because I initially come from a primary care setting where you're seeing a lot of patients in a short time period, that if a positive screen means that you have like 15, 20, even 30 minutes of further screening to do with the patient, that's kind of going to put me or a person in a primary care setting where you're running late for your next patient. So I think it's important to focus on efficiency as well. I think that could help with staff buy-in as well, because if the screening tool is a little bit quicker or more efficient, staff are more likely to employ it on a more frequent basis. And at the end of the day, I think the single question drug screen when screening for opioid use disorder is a potentially good option. So as the title implies, the next step, if you get a positive screen, is to employ a brief intervention. There's a wide array of brief interventions that any one person can employ in their clinical setting. Like I mentioned, the NIDA quick screen kind of has some built-in resources that you can become familiar with and find out which ones kind of work for your style of interacting with patients. But as far as like a quick, effective guide for performing brief interventions. This is one that I came across back in medical school in Chicago. It comes from Rush University. And I think it's kind of a really good resource that you could kind of just print out cards like these, stick them in your pocket, keep them at your desk, so that when you're interacting with patients, especially when you're starting and haven't really developed your style of motivating patients, working on motivational interviewing, something that you can keep on hand to kind of remind you that if you get a positive screen, what are some of the brief interventions that you can employ to help the patient reach their goals. You don't have to do every intervention on here, but it's just kind of like a menu that you can select from, working on practicing different ones, figuring out which ones fits your style and which ones you're getting better results from patients, kind of focused on and based around motivational interviewing. So when I was doing training in medical school, I kept one of these in my pocket when I was seeing patients. And if I knew I was going to be encountering a patient who might have a substance use disorder, would just kind of pull it out and familiarize myself with some of the brief interventions that I could use. And kind of after getting an idea of what the patient was going through and what their goals are, try out various ones to see what kind of results I could get. All right. So screenings, brief interventions, and now moving on to referrals to treatment, which we'll kind of spend more time discussing today during the lecture. Again, focusing in particular on MOUD or medications for opioid use disorder, and in particular on methadone as well. So you decide that you're going to implement one of the screening tools we discussed, and you, in your clinic or place of work, decide to pick the single question drug screen. You employ it on your first patient that you encounter, and the result comes back positive. You provide a brief intervention, one of the ones that was noted on the card previously, and your patient asks for a referral to treatment for fentanyl use. Which of the following statements are true regarding medications for opioid use disorder, or MOUD? Option A is that a prescriber will need a DEA X waiver to prescribe Suboxone to treat opioid use disorder. Option B is that there are 2 FDA-approved medications to treat opioid use disorder, Suboxone being one of them, as mentioned in option A, and methadone secondarily, as we've mentioned a few times already. Option C is that as methadone is so highly effective in treating opioid use disorder, that federal guidelines ensure easy access to methadone in all 48 contiguous states. Option D is all of the above are true. And option E is none of the above are true. So I'll just pause for a couple seconds here, allowing people to think about the question, maybe bounce around in your minds what you think is true regarding treatments for opioid use disorder. And then we'll kind of take a deeper dive into why these statements may be true or false. All right. So regarding referrals to treatment for opioid use disorder, none of the above statements were true. It's no longer true that the prescriber would need a DEA X waiver to prescribe Suboxone. It's not true that there are 2 FDA-approved medications to treat opioid use disorder. There are actually 3. Suboxone and methadone are the most commonly used and most commonly recognized, probably, but the third one would be long-acting injectable naltrexone or Vivitrol. And the third statement, option C, is probably the most false of all of the options here. And we'll talk a little bit more about why that is today. But it is definitely not true that methadone, well, it is highly true that methadone is so highly effective in treating medication or in treating opioid use disorder. It's probably one of the most effective medications, including along with Suboxone in treating any current illnesses. But federal guidelines do not ensure that it's easy to access in all 48 contiguous states. All right. So this is just kind of going over the 3 medications that are FDA approved currently to treat opioid use disorder, and using some of the ways in which researchers evaluate their clinical impact on patients' lives if patients are taking these medications on a consistent basis. So 3 medications, like we mentioned, buprenorphine, also known as Suboxone when it's the combination product, methadone, and XR naltrexone, or better known as Vivitrol. XR naltrexone increases treatment retention and reduces non-prescribed opioid use, but doesn't have as much clinical evidence regarding the reduced risk of overdose or all-cause mortality as both methadone and Suboxone or buprenorphine do. And buprenorphine and methadone, as I hinted at earlier, are extremely effective in reducing overdose rates and all-cause mortality. And depending on which resource you're looking at, which study, you'll see anywhere from 40 to 60% reductions in overdose rates and all-cause mortality. And so I'll tell patients that reduction in all-cause mortality means that not only if you're taking these medications on a daily basis, will they prevent your likelihood of overdosing and dying from an overdose, but they'll reduce your likelihood of dying from things like heart attacks, strokes, getting hit by a car, any other reason that a patient might die. In addition to these benefits, both methadone and buprenorphine have been shown to reduce risk of infections like HIV and hepatitis C. So I think that's important to talk with patients about as well. And kind of what we'll try to hit home here is that with the opioid overdose epidemic being as sustained, previously worsening, showing a little bit of signs of improvement, as we mentioned in the earlier slides, that if the problem is this large, if there are so many people dying from opioid overdoses and having their lives negatively impacted by opiates if they're not overdosing, why are these medications not easier to access? Back to the question, I was considering leaving this slide out just because, as you can see, it's like kind of a little bit of old news. But the more and more that I kind of try to tell myself that, the more I kind of realize that that's probably because I work in a silo, like I work in an addiction clinic, I work in a methadone clinic, an OTP, an opioid treatment program. And so to me, in my little world, patients that walk through our doors, it seems like it's incredibly easy, although we still have ways to improve to access buprenorphine or Suboxone. But I get a little hint of reality every once in a while when I see that patients are still coming to our clinic in central Tucson that are traveling as far as like Douglas, which is probably about 2.5, 3 hours away. I have patients that I take care of from Benson, which is an hour away, Sierra Vista, probably like an hour and a half, 3 Points, an hour away. And so it's clear that either this information hasn't spread to certain parts of the country, or that although it's spread, people who would be able to prescribe life-saving medications like Suboxone in particular haven't really started to do so. So I think that it's important for a group of people that's interested, self-selecting, I imagine, for attending this lecture and promoting rural health, that we're kind of getting the word out there that like, hey, you don't have to travel to Tucson, you don't have to travel to Phoenix to get Suboxone, that your primary care provider in Douglas or Benson or Sierra Vista actually can prescribe the medication to you. I know that there's resources like the ECHO programs where there's mentoring between physicians who have a little bit more experience prescribing Suboxone and prescribers who don't have as much experience. But it's important, I think, to keep on advocating for the members of our community and advocating for the people who have the power to prescribe Suboxone, that it's not an acceptable answer anymore, that you just don't have your X waiver and that you can't prescribe Suboxone. And kind of, I guess, to take a step back, that before December 29th, 2022, to be able to prescribe Suboxone, which is one of the 3 medications that can be used to treat opioid use disorder, you had to do an extra training, which was about 8 hours long, that would give you a special type of DEA license. And within that kind of increased regulation, there were limits on the number of patients that you could prescribe Suboxone to. And so for a certain period of time, you could only, I think it was prescribe Suboxone to 50 patients. For a certain period of time, you could only prescribe to 100 patients. And I think there was an upper limit of 200, which is kind of like, in my mind, a little bit dumbfounding. When I was training in primary care, I treated a fair deal of patients with chronic pain who were on chronic prescription opiates. And for those patients, there was no limit of how many I could treat their pain with opiates. I didn't have to have them come in for drug screens 8 to 12 times a year. I could just kind of prescribe oxycodone or morphine under my DEA license. But when we're talking about a medication that can be used to treat opioid use disorder and save lives, the precedent was kind of set here with Suboxone, that you had to have a special training to prescribe this medication and that you were limited to the number of patients you could treat, which kind of rode on the back of how methadone's been regulated historically in America. I think that obviously great, the X waiver has been removed, but when you're looking at studies of like the impact of the removal of the X waiver, it kind of shows that more prescribers in aggregate are not prescribing more buprenorphine or Suboxone, but that providers who are already doing so are prescribing a higher volume of it or prescribing it to more patients. So I think that it's important that within our communities that we're kind of continuing to spread this news and information that is almost 2 years old at this point, but seems to still need some traction in getting out there and into the community. All right, so going down the methadone pathway here. Obviously, you can see here another map of America, and this is in particular related to opioid treatment programs, which is kind of the fancy word for a methadone clinic as called out in the federal regulations. But the way that you're interpreting this map here is that the regions of the country, which are showing up in orange, are counties in which a patient or community member would have access to methadone in America. There is currently, on top of the changes to the federal regulations that are coming into effect that we'll discuss more October 1st, some additional regulation changes that people are advocating for, which would allow methadone to be prescribed outside of opioid treatment programs. And if that were to go into effect, people would have access to methadone in the violet and darker purple regions of the country. But you can see even then that there's still large percentages of the country that have counties in which you couldn't get methadone at all, which are kind of the gray areas on the chart. And so it's kind of striking with the opioid epidemic, in my opinion, being so large and sustained that the current status quo was that a patient could only get access to methadone, which is a life-saving medication reducing overdose rates and all-cause mortality by 40 to 60% if you live in one of these orange areas. Like people in the news, places like the Atlantic or New York Times, like articles I've read or podcasts I've listened to recently are starting to refer to methadone as like a miracle molecule, which I think is interesting in light of how effective it might be, that you can only get it if you live in like one of these very few places across the country. So delving into like why methadone is so hard to get access to, we'll take a step way back into the 1930s and kind of go back over the history of methadone here. And so methadone is a synthetic, which means man-made. It's not derived from the poppy like heroin would be. Long-acting, full agonist opiate. Full agonist just means that when it's interacting with the opioid receptors in your brain, it's turning them all the way on. It was actually discovered in the 1930s in Germany. Before World War II, Germany was going through a shortage of morphine. And so German scientists or chemists ended up developing methadone to kind of fill the gap in pain treatment with the morphine shortage. After World War II, when the Allies were victorious, they kind of took ownership or control of German patents and scientific discoveries, and they brought methadone back to the United States. Another name for methadone that you don't see as much is something called dolophine, just kind of like how many medicines have different names. But literally in Latin, dolor is pain and finis means to end. And so literally, depending on where you are in the country or the world, if you're referring to methadone, it kind of means to end pain. And so it's a pain medication. There's a lot of stigma around the treatment for substance use disorders in general, and a lot of facts about methadone in particular that aren't true. And I think it's kind of important to acknowledge those so you can correct people if they're talking about them. But people who don't like methadone or think it's a bad medication, Some people might even say that it's named after like Adolf Hitler. Dolafine is Adolf, but that's not true. It's kind of coming from the Latin roots of the medication, which are to end pain. We'll talk about the narcotics farm on the next page here. 42 CFR is the federal codes which regulate the prescription of methadone for opioid use disorder in particular. Here I'm kind of calling it a tale of two diagnoses, because as you can probably guess by the name Dolafine, that it can be used to treat chronic pain. And if you're a physician who has a patient with chronic pain in America, I could just prescribe methadone to a pharmacy like any other blood pressure medication, birth control, and a patient can pick it up there. But if you're using methadone to treat an opioid use disorder, it's regulated under CFR 42 Part 8, which makes it incredibly hard to access for patients, as you could probably divine from the picture of the United States showing where you can get methadone from an OTP in America. And kind of, don't need to say again, but one of the most highly, probably the most highly regulated prescription medication in America because of all this. One of the first places that methadone was studied in America was a place called the Narcotics Farm, which I think kind of just gives a interesting perspective on where we are today with addiction treatment and methadone. But back in the 1930s, they opened a place called the Narcotics Farm in Lexington, Kentucky. And it was actually called the Narcotics Farm. You can see on the building there that it's emblazoned or chiseled in the stones. And it was kind of, I think, a good example of like some of the lingering stigma we have in America towards substance use disorders. But it was kind of a byproduct of the fact that the medical system didn't want to treat addictions, and even some of the carceral or prison systems did not want to take inmates who had substance use disorders. And so they had to create a special place where a person with a substance use disorder could go to be incarcerated and receive treatment. So it wasn't a hospital because you couldn't leave if you wanted to. You weren't voluntarily admitted, but kind of a hybrid between a medical facility and a carceral center. Within the Narcotics Farm, there was a place called the Addiction Research Center, where they studied a lot of substances that could be used to treat or substance use disorders, as well as recreational drugs themselves. And so in 1946, they started studying methadone at the Narcotics Farm, and it was used to taper people at that time off heroin in particular. It wasn't used for maintenance treatment like it is today. They also studied the effects of things like LSD on inmates at the Narcotics Farm. And it was kind of a ethically questionable place because they would take inmates or patients, whatever you want to call them, from there, and they would study like the acute phase of intoxication by, for example, giving an inmate LSD. And for enrolling in these studies, they would allow the inmates to be paid for their participation with their drug of choice. And so a patient who wanted to enroll in a study could be studied about the effects of LSD on themselves, and then they could actually like bank morphine or heroin to use as a later time as compensation for their participation in the studies. It closed in 1976, around the time of the Tuskegee syphilis trials. People kind of started to realize that the types of studies that they were doing there weren't ethical, and kind of ended up shutting down the place around that same time period. So moving forward, a controversial figure in the field of substance use disorders, but Richard Nixon and his war on drugs. Interesting guy, man of contrast, I think. I think it's important to acknowledge that while there are like incredibly terrible persistent effects of the war on drugs, that Nixon was one of the first American politicians to acknowledge that treatment for substance use disorders was a good thing. That being said, the kind of treatment that he advocated for and ushered in was through a strikingly like punitive criminal lens, the legacy of which we can kind of still see today within the OTP methadone systems. And I think in particular, because of this, it's important to reflect upon the choices of words that we use to refer to patients with substance use disorders, because they do have a large impact on a patient's self-perception and how they feel comfortable within a treatment space. So kind of like moving away from terms like addict or talking about results of urine screens as clean and dirty, but rather using appropriate medical terms like substance use disorder, or the results of a urine screen as being appropriate or inappropriate, because they do have lasting impacts of our patients. In the 1960s, there were actually a few clinics that were using methadone to treat opioid use disorder as maintenance treatment, but in 1973, the Nixon administration codified regulations regulating how methadone could be prescribed in a very regimented system that we still see today in America. This is different in other countries around the world, and the methadone system in America is kind of particular to America itself. But again, it's kind of makes you wonder that this is 1973, 50 years later in like 2024. If we know that methadone is so highly effective in treating an opioid use disorder, reducing mortality by 50%, like why is the medication still so impossible to get a hold of? Kind of placing a particular emphasis here on that, like this piece of legislation, 42 CFR Federal Code, is carved out from all the other pharmaceutical medications that we use in America. All those are regulated under something called 21 CFR, but 42 CFR in particular was created to carve out methadone and regulate it separately from all other prescription medications in America. And since the early 2000s, there haven't really been any changes to 42 CFR, but earlier this year, changes were approved and they're going into effect in Arizona, effective October 1st. So this is just kind of a good example, I think, of the time period in which Nixon was making these changes. This is like an actual journal article published in 1969 in the New England Journal of Medicine, which is kind of like a pretty big journal. I kind of compare it to like if you were like a star high school athlete appearing in like Sports Illustrated. New England Journal of Medicine like carries with it the same weight and the type of research it's publishing. But the actual title of the study, as you can see here, was methadone treatment of randomly selected criminal addicts. Like not making that up, that's the kind of terminology that they were using to refer to the patients that they were treated. And the treatment outcomes that they were actually evaluating for in 1969 relative to methadone were actually like criminal offenses. And so you can see at the bottom of the chart there on the right that they're evaluating for how many burglary charges, assault charges, murder charges, possession of drug charges, gun possession charges that patients with methadone treatment were incurring, as opposed to those who aren't on methadone. And so I think it speaks a lot to kind of how methadone is currently regulated and how Nixon kind of viewed treatment, was that the medication needed to be very tightly regulated, because in the time and in his mind that it was a medication that was kind of viewed as helpful to criminals, which we now know is like entirely not true and false, and that substance use disorders don't discriminate, and across like various socioeconomic demographics that like the prevalence can be relatively the same. So if we want to go a little bit deeper into this legacy of like Nixon and the war on drugs and methadone being regulated by federal codification that was kind of based in academic studies that were evaluating decreased rates of criminality, I think it's kind of telling to see that in America, there's currently 2,100 OTPs, and so those orange spots on the map previously represent those 2,100 OTPs. But the fact of the matter is that the real amount of OTPs that a member of your community might have access to is actually much lower, because the Federal Bureau of Prisons is actually the largest OTP in America. And so that kind of means that you can't access those OTPs unless you're incarcerated, which is pretty sad. And a good example of that, I think, is West Virginia, which has one of the highest overdose rates in the country historically during the last few decades, and only has 15 opioid treatment programs, 6 of which are only accessible within the prison or jail system. So a little bit shocking there, I would say. Arizona, like as of like 2 weeks ago, and I pulled this data, had 74 opioid treatment programs, and this is kind of a screenshot from the SAMHSA website that kind of shows a similar trend, that maybe not the same percentage of 40% as in West Virginia, but a lot of these are located in jail systems or prison systems. So we got Lower Buckeye Jail up in Phoenix, Estrella Jail, 4th Avenue Jail. Yeah, we don't really get into the subject matter here today in this presentation, but a lot of the opioid treatment programs in America as well are kind of currently owned by private equity or for-profit organizations, which have kind of a financial incentive of making methadone a little bit harder to access. So I think that's a conversation for a different day. But I think it's kind of important to understand that aspect of like why methadone might be difficult to access as well, is that some of the companies who operate these clinics make a fair deal of money off of them, which doesn't detract from the efficacy or helpfulness of the medication. But I think that like some of the resistance we're seeing of making methadone for opioid use disorder more accessible is kind of rooted in that kind of piece of the puzzle. This is just a study analyzing like prevalence of mental illness and substance use disorders within the carceral system. But as you can see here, it says that half of inmates were diagnosed with mental illness, 48%, 29% had serious mental illness or SMI, and 20% of inmates had a history of a substance use disorder. And so like a quarter of the patients incarcerated in the country like have a history of a substance use disorder. Which is kind of shocking, and also in light of us talking about previously that the largest operator of OTPs in the country is the federal prison system. This last piece here saying that the mean interval from incarceration to first diagnosis or recognition of substance use history was 11 months after incarceration. And so that means that patients with a history of opioid use disorder that are getting sent to jail or prison are having to like wait a year to get actual treatment if they're ever actually accessing it during their incarceration, which I think is extremely unfortunate. And so this is kind of getting a little bit more to present day here. During the COVID public health emergency, or PHE, there was an unintended experiment that was kind of performed on methadone. One of the common statements that you would hear people make who want to keep methadone regulated the way that it is that it's kind of a dangerous medication, and if it gets out to the community, it's going to harm the community, that people will become addicted to methadone, that people will overdose on methadone. But because of the COVID public health emergency, I guess I need to explain too that to get methadone from an OTP, like for the first 3 months, you have to go to the clinic 6 days a week to get your dose of the medication. Can't be sent to a pharmacy, and if you miss your dose, you don't get any medication that day. Because of the safety factors from COVID, they liberalized these rules during the public health emergency. And so clinics were able to give patients a week or two of medication at a time. And so they did studies on this time period, kind of see if some of these previously believed but unsubstantiated beliefs like held true. And it actually showed that they didn't. This graph on the right here showed that the percentage of drug overdose deaths involving methadone during the COVID public health emergency actually decreased. And when you're looking at things like patient autonomy, when they're on methadone, that increased. Methadone-related overdoses decreased, like we talked about. Patients felt that they were more highly engaged in treatment, had higher rates of self-efficacy, as well as strengthened recovery, reduced interpersonal conflict for patients, that there were no changes in urine drug screen results, that ED visits did not increase, and that there was not actually an increase in diversion of the medication, which is kind of like one factor of why people like still want methadone to be so highly regulated, is that there's a fear that it'll get out into the community, like I mentioned, and cause further substance use disorder, or even, unfortunately, overdoses, which kind of played out to not be true during this time period. So because of this, the movement to make methadone more accessible within the United States kind of started to gain momentum in combination with the worsening rates of overdose deaths. There was pressure to kind of look back at this piece of federal code 42 CFR Part 8 and kind of make it a little bit more modern. Although many would argue, including myself, that there's still a ways to go. But some of the things that have been changed coming into effect in October are things like admissions into opioid treatment programs. Currently, you have to get an evaluation by a practitioner within the opioid treatment program itself. But they're changing the regulations so that if a patient with an opioid use disorder, maybe on Suboxone, that's kind of failed treatment with Suboxone, is interested in getting methadone, if you follow appropriate channels and have a good relation with your local OTP, if you're like fortunate enough to have one in your community, that practitioner or physician could just send their note to the medical director or practitioner at the OTP and get them started on methadone a little bit more quickly. Take-home doses, which I think is interesting to like talk about too, that at a lot of clinics, it's referred to as take-home privileges, which I think is kind of an interesting choice of words to unpack. That like we have a life-saving medication called methadone. Patients are having to come to a clinic 6 days a week to get it. And you're referring to their life-saving medication as a privilege, right? It's not like anyone's referring to someone's insulin or birth control or antidepressant as a privilege. But like within some of these treatment settings, that it's like a privilege to have more easy access to your medication. And over the course of a year, currently it would be that you would have to be in treatment for a year with appropriate drug screens and not missing days in clinic. You could get a week of medication at a time. But the changes to the rules make it so that you can receive take-home doses within the first week of treatment under certain conditions. I think that's probably going to be the minority of patients just for safety reasons, because you kind of have to slowly increase the dose under supervision because it's a full agonist opiate. It can cause overdose. But patients, based on like patient-centered care and physician decision-making, can start getting more access to their medication at a much earlier rate, which I think is going to help retention and treatment. Because the fact of the matter is that these incredible reductions in overdose mortality and all-cause mortality and retention and treatment only apply if a patient is taking their medications on a daily basis. And I would probably posit that if it's a little bit easier to take the medications, we'll probably retain more patients in treatment. You're also allowed to start methadone via telehealth, which like doesn't solve the problem for like not having a OTP in your community, because you still can't prescribe it to a pharmacy, but that might increase patient access to care as well. All right, and so what can we do? Getting a little bit more into the referral to treatment work here of if you're working in a community that might be close to an OTP, how can you help your patients get the care and access to the life-saving medications that they need and deserve? So like we talked about earlier, I think it's important to continue to spread the word, spread the word or work, because there's still more work to be done, but misspelling there. Spread the word that the X waiver is dead. Like I'm still encountering a fair deal of patients coming from communities which have a handful of practitioners who can prescribe Suboxone, because anyone with a DEA license can prescribe it, and you kind of have to have a DEA license to practice medicine. But we still need to let these people know and these patients know to advocate for them, and so that they can advocate for themselves, that they shouldn't have to drive 2 hours to Tucson once a month to get their Suboxone prescription. So that's one thing that we can do to help connect patients to treatment for their opioid use disorders. The next thing that you can do is kind of within your various communities. If you go to the SAMHSA website, as you can see on the bottom right-hand corner of the screen here, if you just kind of Google SAMHSA opioid treatment programs, that it pulls up a search tool. You can select your state that you're currently in, which for many of us is probably Arizona, as you can see in the top right-hand corner there, and it pulls up the list of the 74 OTPs within Arizona, stratified by state or stratified by city. And so you could figure out where you're working and see if there actually is an opioid treatment program within that community. If you do have one within your city or within your county, I think it's important to try to reach out to people like myself, the people prescribing methadone, the medical directors of these clinics, and try to see how you can help connect patients with care. You could offer to do screening exams that would allow the patients to kind of circumvent a often lengthy intake process at the clinics. When a patient shows up to an OTP, it usually takes like anywhere between like 2 to 6 hours to kind of do a full clinical intake and get assessed by a physician and get your medication for that day. But I think if opioid treatment programs are able to partner with other community clinics, I think this can kind of speed up the process and increase access to care. And if you're one of those people who may not have an opioid treatment program in your county, when you're pulling up the OTP program directory on the SAMHSA website, there are ways that you can continue to advocate for change. I was talking about earlier the graph of the United States with the orange and the purple being the counties that could have more increased access to methadone. That's kind of revolving around something called MOTA, or the Modernization of Opioid Treatment Act, which is currently a piece of legislation that's working its way through the federal government, currently stalled. But that would allow methadone for opioid use disorder to be prescribed by licensed practitioners, physicians, nurse practitioners to pharmacies rather than the current system in which methadone is prescribed. And one of the groups that's working on kind of advancing that legislation is a place called the National Coalition to Liberate Methadone. So I have their website listed here. They actually had a national conference recently that was pretty neat and well attended to kind of talk about how we can make this life-saving medication more accessible to our patients and community members. And hopefully we'll make the referral to treatment portion of getting a patient connected for an opioid use disorder a little bit easier. And so I'm running up on time, so we'll just kind of skip through these historical take-home guidelines. But these are the old ones, which I think are telling here. It talks about like abuse of drugs rather than a substance use disorder, absence of criminal activity, which like we're still evaluating patients as criminals to get access to their medications. And the newer take-home guidelines based upon the federal regs kind of remove some of that stigmatizing punitive language, talking about patients with substance use disorders as like criminals. So I think that's a step in the right direction. Yeah, little quote in the day. I was originally thinking that I would work in global health, but I think Paul Farmer was one of my big role models, and a lot of public health and social justice work kind of applies to the treatment of substance use disorders as well. And Dr. Farmer kind of asked here relative to global health applicable to addiction treatment, in my opinion. He said, if access to healthcare is considered a human right, who is considered human enough to have that right? Got an email at the bottom here. Feel free to reach out if you have any questions or want to connect. And then we got a few minutes left for question and answer.
Thank you so much, Dr. Grant. So there are a couple of questions. First one is thoughts on S2BI versus NIDA, or single question. Any differences when screening adolescents versus adults?
Oh man, that's a very pointed and a little bit deeper than my knowledge base might be. Yeah, I think that there's not like one kind of like the brief intervention, that there's not one that's like the appropriate answer for every clinical setting, and that it's important to kind of trial and practice different like screening tools in both brief interventions as well. Because it's like anything in medicine, it's not just like the medication or the intervention that's like the magic portion of it. It's also like the patient and the person having the conversation as well. And so there might be a certain screening tool that's like for one practitioner like works really well, or a brief intervention that works as well. But if you try to have like another clinic or another practitioner employ the same screening tool, that it might not have the same impact. Same with the brief interventions as well. I think the question about adolescence is like in particular like very interesting. And unfortunately, like the reality is that a lot of substance use disorder research is performed on adults. But the reality is that the amount of people in the community who are developing substance use disorders, if you're looking at things like vaping, access to cannabis increasing, even things like opioid use disorder, it's like beginning at a younger age. And that was actually one of the changes made to the federal regulations for regulating methadone is that previously you couldn't, or it was nearly impossible to get on methadone if you were under 18 years of age, and those have been loosened as well. And so like, to answer your question, don't have an answer as which I would prefer or recommend. And as far as the adolescent population goes, not a lot of research that I'm familiar with on far as like distinguishing that from like a more adult typical population. But good question. I wish I could be more helpful, and if you email me, I could try to find you a better answer. But thanks for the thoughtful question.
And then I think there was a follow-up to that. They put that in my discussions with pediatricians, many, if not most, are not aware of the waiver elimination.
Yeah, I think that is telling, right? Like, I think if you're like attending lectures like this and working in clinics that I work in, that patients are like, I mean, this lecture is kind of about referral to treatment. But like for buprenorphine or Suboxone, at least, like if you have someone who can prescribe, I don't know, like what's a common pediatric medication like amoxicillin, like albuterol, an inhaler. If you're talking about like a nurse practitioner or a doctor who can prescribe your child albuterol, which like is also a life-saving medication, like they can prescribe legally buprenorphine. And I think it just tells us that we still have a lot of work to do in getting that kind of word out into the community. I think that part of it is that people aren't really receiving this training in medical school. And so it's a level of discomfort that like prescribers have. But I think unfortunately too, like in America as a whole and in medical communities in particular, that there's a ton of stigma around substance use disorders. And some of these prescribers who say that they still can't prescribe Suboxone, it's like a mix of being uncomfortable doing so and like also kind of like, I don't want these types of patients in my clinic, which I think is incredibly unfortunate and harmful. And so I think that when you're interacting with people in the medical community that have the power to prescribe life-saving medications, that it's important to advocate for this knowledge being wide held, and that it's like not acceptable anymore to like not feel comfortable to prescribe a medication that like can save someone's life. Because the reality is that like in between that week or two or a month or two that you're not treating an adolescent or an adult substance use disorder, they could very easily overdose and die. And I think that that's kind of a inexcusable medical error probably in the current landscape of like how these medications are regulated.
Any other questions for Dr. Grant or any clarifications? Okay. Okay, if no further questions, thank you so much, Dr. Grant. Your presentation was amazing. Again, we'll have a recorded version of this available to everyone. And yeah, that's all. Thank you so much, everybody, for being here.
Thanks for your time and letting me talk.